Welcome. I'm Larry Tanenbaum, and it's my privilege to welcome you all here while we're live at RSNA 2024 to this Applied Radiology Roundtable series on the latest trends in Alzheimer's imaging and management. For this module on the role of molecular imaging in Alzheimer's disease, I'm joined here by my friend Dr. Anna Franceschi, who is an associate professor of radiology at Lenox Hill Hospital in New York City. We're also joined by Mr. Adam Samchuck, who is a product manager for PET Solutions at Siemens Health and Ears. Welcome.
Thank
Nice
you
to
so
have
much
you
for
here.
having us, Larry.
So, there's so much to get into here with molecular imaging and Alzheimer's disease. I almost don't know where to start, but maybe I can ask you, Anna, if you can give me just a little historical vignette on how we got to where we are now with molecular imaging of neurological disease.
Of course. So, traditionally, really, the accurate diagnosis of Alzheimer's disease and related neurocognitive disorders has really been hampered by the lack of non-invasive biomarkers of the underlying pathology. And there are some statistics that highlight that nicely. For example, it's been shown that about a third of patients diagnosed with Alzheimer's disease actually lack AD-type pathology at autopsy. Similarly, in the community setting, about a third of patients with early signs and symptoms of Alzheimer's disease go undiagnosed. Meanwhile, healthcare costs, as we all well know in this sphere, are astronomical, and this all really highlights an urgent need to find accurate methods of detection and then subsequently therapeutics. So what we are able to do as radiologists from a molecular imaging standpoint is essentially differentiate patients with Alzheimer's disease from other types of neurodegenerative disorders, and primarily we think about amyloid, which are the beta amyloid plaques that accumulate in brains of patients with Alzheimer's disease, and then tau, which forms the neuropil tangles that similarly the two together form the underlying dual proteinopathy of Alzheimer's disease. And I think as we will go into further detail, as we look towards the future, it's not just amyloid and tau, but then we have other biomarkers of neurodegeneration and neuroinflammation, synaptic density, et cetera.
Yeah, it's an exciting topic. What I remember, before the availability of disease-modifying therapies and some of the clinical trials, was that molecular imaging of neurological disease was FDG-based. What unique insights do we get from the amyloid agents?
Well, let me just first tell you that I still think strongly that there is a clear role for FDG. And I think the purpose of FDG is essentially to provide a differential diagnosis of the underlying pathology and allow us to speculate on other pathologies and not just Alzheimer's disease. We talk about Alzheimer's disease because it is the most frequent one, but certainly there are many other disorders to keep in mind. In terms of amyloid imaging, first of all, amyloid imaging is so crucial because having a confirmation of both amyloid and tau biomarkers allows us essentially to make a definitive diagnosis of Alzheimer's disease ante-mortem, something that was previously only done by brain biopsy. And now, of course, as you mentioned, there are these very exciting anti-amyloid monoclonal antibodies on the market, and really the amyloid PET allows us to identify and select the proper candidates for treatment.
Yeah, wonderful. I think that's a wonderful introduction. So, with these therapies, you would expect that there would be a boost in volume that the imaging centers are seeing, and you might actually expect that they would look to the manufacturers for opportunities to make these scanners more efficient.
Yes.
Because I think, I'll give you an example just as an aside, and I hate to steal Dr. Franceschi's thunder here, but at RadNet, where I was until just recently, their PET volumes have gone up 5,000% over the last 6 months. So we look to the manufacturers perhaps for features that might give us the ability to do more patients per hour.
Yes.
Can you elaborate on that?
Absolutely. I mean, all of our Biograph systems, all of our Biograph PET CTs are high resolution systems, so we're going to deliver the image quality you need. But with our LSO-based systems, with time-of-flight performance, we're really focusing on enhancing PET performance further so that all of your clinical scanning can speed up and that you can increase your range of clinical offerings and improve your flexibility. So, not just the speed of your neuroscan, but we want to make sure you can do your oncoscans faster as well so that you can make room for these additional ologies.
I would say that I have been impressed with the improvement in spatial resolution we see from the later generation machines. I mean, a lot of molecular imaging, please correct me if I'm wrong, has been in the hands of people who are molecular imaging specialists. And as the neuroradiologists get more involved, and I'm going to ask you to opine on that over the next few minutes, I think we respond better to higher resolution images. They correlate better with our other studies.
Yeah.
Is it fair to say that the technologies you bring to bear are going to make that resolution higher?
I mean, and to your point, the importance of that differential diagnosis, and if there's anything that we can do to help improve the accuracy or diagnostic confidence of those images, I believe it comes down to that high resolution and spatial resolution, but then also quantification as well. So how well can we quantify beta amyloid plaque or even tau, and how will that help in the research space in determining the effectiveness in treatments?
And I love that you brought that up. And feel free, why don't we stick with quantification, the value and how it's done? Why don't we stick with that? So go ahead, whoever wants to speak next.
Absolutely, and I can speak, for example, specifically for amyloid PET. Historically and traditionally, we talk about it being a very binary modality, very positive, very negative. When the fact of the matter is, once you see a good volume of these scans, the 10 or 15% are really visually indeterminate, fall into a gray zone, and that, I think, is where the role of quantification seeps in. And it's very exciting now. I think there are 2 FDA-approved platforms that allow even for a centiloid value to be offered, not just in the research setting, but very specifically in the clinical setting. And these centiloid scores have really been ingrained in all of the clinical trial of the monoclonal antibodies currently in the market. And it is so refreshing for myself as a clinician, not just as a researcher, to be able to offer this information to my neurologists, who can then put it in perspective on the patient's clinical history, other biomarker values, and then come to arrive at the correct decision, correct treatment plan for that individual.
We are very excited to bring not only the beta amyloid, but the tau quantification, and the centiloid scoring is incorporated into that cortical analysis software. So we know researchers are looking to pull data from a number of different sites, and so they might be using different beta amyloid tracers. So bringing that all together with the centiloid score normalization is really exciting.
Certainly, I think the exciting news is the tau quantification that you have as well. Again, traditionally we very much think of tau as a research radio tracer. However, more recently NGS and other MACs have confirmed clinical reimbursement for these agents, and for example, we've performed a couple of them already clinically, and again, I think the value of quantification, especially with some of these more novel molecular imaging agents, cannot be overemphasized.
That's great. I do want to expand on the reimbursement landscape in a moment, because I think that's fascinating. But I want to start with the fact that it is now permissible to get more than one amyloid PET scan in your life. And you would think that this quantification, the better precision in quantification, the better accuracy in quantification would be critical when physicians start to use these tools as a way of doing surveillance and monitoring the effectiveness of therapy. Would you agree with that?
Absolutely. I think they are crucial for monitoring target engagement and treatment response. In fact, clinically, I've had a couple of patients that wish to switch from one agent to another, and a second amyloid PET is done at that time to evaluate the efficacy of the patient's treatment so far. Similarly, many patients are now approaching benchmarks of either 12 or 18 months, and it is very clear that they will be monitored by second or third amyloid PET at that time. And again, quantification is indispensable, because that is how these decisions were made in the clinical trials that eventually led to FDA approval of these therapies as well.
You did mention that it's not widespread, this availability of centiloids. You mentioned that Siemens is one of 2 vendors that are providing this, but it sounds like this needs to become standard of care.
Absolutely. Absolutely. I think looking at amyloid PET through a binary lens is outdated, and it is not sustainable in the current landscape of disease-modifying therapies.
And I'm assuming too, the unbundling of payments might further help increase the access to some of the care as well.
Absolutely. At my center, and I'm sure at many centers that are around the country, we are not offering amyloid PET at our Article 28 facilities, and reimbursement is of great concern. On the one hand, we were so elated when, after 10 years of a very restrictive NCD, that was finally lifted once disease-modifying drugs entered the market. But then the current bundling of reimbursement remains a big problem. And again, we are tentatively hopeful as we look towards 2025 that will bring significant changes and shifts in the imaging pathway for patients across the country.
Okay, so just as an aside, because there's a lot of great information here, and I'm almost overwhelmed by it. Let me just go back one step. Could you just give me a sense as to how consistent and ubiquitous reimbursement is for an amyloid PET as a rule? Is it something that third-party payers as well as CMS is paying for consistently across the country?
The answer is yes. In my practice, and I think the experience has been similar throughout the country, we went from scanning maybe 5 to 10 self patients before October 2023 to scanning 80 to 100 patients a month immediately after CMS put out that statement highlighting their coverage of more than 1 scan per patient per lifetime. And we have had no issues with the reimbursement so far. Our local MAC, confirmed coverage, and as far as amyloid PET, that has been consistent, throughout the country. I think there are many more questions about tau PET, but the current data that we have seems very promising, and it seems to be slowly but surely taking off as well.
That's actually very exciting, and I do want to just touch on tau PET again to tease a little more out of you. But before we do that, can you give me a better feeling for the impact of the unbundling on whether practices can actually bring these modalities to bear?
I think it will bring tremendous change because many institutions, especially those that don't have more than one PET center, are faced with a decision of, whether to allow this or not, operate at a loss, but then, make it up with patients who are undergoing active therapies and then having the therapies, the infusions, the monitoring MRI scans, or they don't, and then they are not able to provide care for this relatively significant portion of the dementia patient population. To give some context, we have 8 PET imaging centers in Northwell, and we are able to currently provide amyloid PET at only 2, and 2 that are not exactly geographically conveniently located for the majority of our patients. And I'm sure on account there are patients who are falling through the cracks.
Do you see the same thing happening in private practice, the same challenges that you're seeing in at Lenox Hill?
Well, I turn that question over to you, Larry. I am sure you are the ideal person to answer that.
I am really no longer affiliated with RadNet, but they do seem to be pretty happy to provide, roughly 500 scans per month. As you know, the economics at an outpatient center are different from the economics on inpatients, and I don't think that we need to focus on that detail right here. I have a couple of questions that I'd like to get a little more into. Should neuroradiologists step up and be the primary readers or more actively involved with these studies, or should they just accept what comes back from the molecular imaging section and try to figure out how to make that work?
So I do certainly have some bias as a neuroradiologist running a brain PET service.
I wouldn't have suspected that at all.
However, I do think that in 2024/2025, providing both the structural and the molecular imaging data is the way to go. The findings of structural imaging, such as the degree of vascular burden, atrophy pattern, the presence or absence of microhemorrhages, really do impact how I interpret my PET imaging as well. And I think providing both sets of information to the clinicians at the same time, again, really does impact patient care in a meaningful way.
So one of the themes of this series is a call to action. What do we need to do as a neuroradiology, as a radiology community? Would you say part of that call to action would be to get up and get out of your MR and CT silo and get involved with the molecular imaging side of imaging this patient population?
Certainly, and I think neuroradiology fellowships should, especially those that do not have a focus on brain PET, need to start rethinking what they're doing. I know many healthcare centers in the New York City area that are struggling to find neuroradiologists that are trained in brain PET, and in fact many academic sites and many of my academic colleagues, including myself, are training neuroradiologists in-house to be able to meet the ever-growing demand of brain PET in clinical practice.
I would think what happens in private practice is the hottest thing. We're always looking for guys trained in the hottest thing, and Alzheimer's imaging, molecular imaging may well be that hottest thing that makes you very attractive to employers. Now, I kind of cut off the discussion on tau PET, but I think that's a very exciting opportunity there. Give me a little more feedback as to where that's going. You mentioned there is some payment, because I wasn't even aware there was some payment.
Yeah.
And give me a sense of the next 12 months, what you expect in terms of breadth of payment, how much use. I know there aren't that many approved drugs, maybe only one.
Correct.
Do you expect more approvals? Give us some discussion on that.
Currently, there's a single agent that's FDA approved for Talsapir or Talvid. There are a couple of other contenders, including one, PI 2620, that currently has orphan drug status with the FDA for non-AD tauopathies, such as PSP or CBD. However, I think for the foreseeable future, we are stuck with that single agent, at least for the next couple of years. Now, in terms of the role of tau PET, I think it is on the precipice of becoming truly clinically relevant. Drug trials of anti-amyloid drugs have clearly shown that patients with lower tau burden do have a far better response, statistically significant better response to anti-amyloid drugs than those with high tau burden. And that's not insignificant for decision-making process, given that these drugs do have, as we all know, a very high percentage of serious and concerning side effects.
Not to mention high cost. It would seem to me naively that tau burden should be used as part of the decision-making process, so whether to put patients on these drugs.
Absolutely. Yeah. Not to mention that there is a significant number of patients that have age-related amyloid accumulation that has nothing to do with underlying AD, and at the end of the day, really a positive tau PET in a patient that has positive amyloid biomarkers is the only way to definitively establish Alzheimer's disease as the cause of underlying cognitive.
Do you ever expect the criteria for going on these therapies will include a tau PET?
For sure. There was a lot of excitement with the most recent drug to receive traditional approval, donanemab or Kinsula, since tau burden was one of the key criterions that was used in the trials. I think at the point of the decision, it was thought that this would be too high a bar for enough centers to be able to achieve, but I think we are moving in that direction for sure. And certainly when there is an tau targeting therapeutic, which will happen in the near future, tau will be here to stay.
Very exciting. Adam, what can, from your perspective, what can you do to make Dr. Franceschi's life a little easier and her patients a little easier?
We want to continue to listen and understand what's needed so that we can continue to bring things like the beta amyloid, the centiloid scale, the tau quantification. Interested to see what it does to help develop the field further, and whether it's a software solution or a particular a new way of looking at imaging. We're ready to listen. And excited to explore what we can deliver.
And I think in terms of equipment, there's a lot of excitement and buzz about head-only PET systems, so not whole body systems, but those that allow you to image only the brain. I think you can speak to this more than myself, but my understanding is that there are AI tools used for attenuation correction, and the resolution is. At least the examples that I've seen.
Especially when you are going to potentially do imaging again and again on patients, and you want to reduce that CT radiation burden as well. Having those solutions where you can use a CT-less attenuation correction is really interesting.
So you mentioned the CT radiation, and we are talking about a neurological disease that has a primary entry in a brain MR and a diagnosis, in this case, that comes from a PET scan. It would seem to me that a PET MR might be the perfect place. And as you know, since I'm talking to the MI guy, it's not MR PET, it's PET MR.
Yeah.
Might be the perfect place to offer a patient-centered solution. What are your observations on that?
I think it's very exciting. The opportunity to have those modalities, CT-less as well, but having MR in the same space that can accommodate the MR imaging that's needed, the anatomical imaging in combination with your PET simultaneously, and how could that potentially help in terms of that differential diagnosis?
I know, as someone who wrote the first neuro-PET MRI textbook on the market,
Who knew?
I can only echo and emphasize those same sentiments. I think it goes for that same question that you had about neuroradiologists interpreting these studies. I think especially with disease-modifying drugs, which are expensive, with a high percentage of side effects, having both molecular and structural imaging information ideally at a single convenient session for the patient is the ideal way to go.
Yeah, I think it's a very patient-centered imaging move to try to use a PET MR. The only question I have naively is would there be a reimbursement issue? Can you commit to reimbursing for a PET before you've done the MR that determines that patient might still be eligible for therapy? Do you think the payers will get in the way of doing them at the same time?
There is certainly still some reluctance and hesitation, especially since there's not a dedicated CPT code for PET MRI. You know, in my experience and kind of the situation has been that typically, you know, as long as both an MRI brain and a PET are ordered by the referring physician, the reimbursement claims seem to be going through.
That sounds great. So any last comments from either one of you to help close this off?
No, we're excited to see where the field goes and how else we can support and continue to provide solutions that enable you guys to continue doing your research and advance care.
And, you know, from my end, just 2 years ago, we were at a place where there was not a single new therapeutic for Alzheimer's disease in 20 years. Now we have 2 drugs that have traditional FDA approval. I'm just excited to see what we will be discussing at the next roundtable at RSNA 2025.
2025, that's exactly right, which will still be the same week in 2025, in case you're wondering. All right, well, that was a really exciting discussion. And as a relatively molecular imaging naive neuroradiologist, I found lots of inspiration here and lots to learn. So I think this is a good time to wrap up our discussion on molecular imaging and Alzheimer's disease. I would very much like to thank my impressive panelists, both Dr. Anna Franceschi and Mr. Adam Samchuck from Siemens, for joining me in this roundtable series on the latest trends in Alzheimer's disease imaging and management, hosted by Applied Radiology with sponsorship from both Siemens and Agora Care. Thank you very much. Really, thank you very much.